Good afternoon. Firstly, I just want to thank everyone for being here. I must say it's been quite nice being able to sort of watch and also give all these webinars from the comfort of my own couch in my slippers and woolly jumper. It's quite a nice change. So my name is Richard Field. I graduated from the University of Glasgow in 2011. I'm an accredited member of the British Academy of Cosmetic Dentistry, and I work out of two multi-speciality private practices, one in central London and one in Bristol. My true passion lies in minimally invasive restorative dentistry, so I like to restore teeth while still respecting both natural biology and aesthetics. It really does excite me to be able to help patients achieve their aesthetic goals with as little biological sacrifice as possible. In general practice, something which you will likely encounter on at least a weekly, if not a daily basis, are patients affected by white lesions on their front teeth. White lesions affect a large proportion of the population and can have some pronounced social implications. Patients will often feel embarrassed by how their teeth look, but have either been told that nothing can be done, or they'll be too nervous to ask, or the only solutions that they've been offered up until now have been relatively invasive. But in an ideal world, we'd remove these spots in a simple, affordable, and above all, conservative way. It's situations like this which we are trying to avoid. These are restorations which have been placed to cover lesions. But in recent years, patients are becoming a lot more dentally aware, and as a result, they are less inclined to accept more traditional and generally more aggressive treatment options. But before we delve into treatments of such lesions, we first want to take a look at what makes up healthy enamel. Enamel is the most highly mineralized tissue in the body, looking around about 96% hydroxyapatite and about a 4% organic fluid content. With white spot lesions, there's a slight difference. In white lesions, the mineral phase is reduced and replaced in some part by more of these organic fluids. Histologically, the majority of white lesions are characterized by hypermineralized subsurface enamel, but with a relatively intact surface enamel layer. It's important to properly diagnose the etiology of these white lesions, as the etiology will often change the way we approach treatment. I like to split the diagnosis into pre- and post-eruptive changes to the enamel. So changes that will happen during the development of the enamel, or changes once the enamel is exposed to the oral environment. Let's start with pre. One of the most common lesions that you'll probably encounter is fluorosis. And fluorosis is a hypermineralization of the enamel caused by excessive incorporation of fluorides during development. You tend to get symmetrical involvement of groups of teeth, groups of the same teeth. You'll often get horizontal, so more or less convergent white lines. Think of these as sort of rings on a tree. If you cut through a tree, you can see what points during the tree's development and certain things have influenced the growth. It's the same sort of with the fluorosis. It's at what time this enamel is affected. You can get chalky areas that give the teeth a parchment-like appearance, and in more severe fluorosis lesions, you can get brown discoloration as well. Trauma to primary teeth is also a cause of white lesions in the permanent dentition, because this is caused by damage to the developing tooth germ underneath the primary tooth. These tend to be more well-defined and located more in the incisal third of the tooth. It's generally one tooth, but you can get neighboring teeth affected, and sometimes you can also get the opposing tooth affected if it has been involved in the trauma as well. Molar incisal hypermineralization is another one of the common white lesions that you will see. You tend to get one or several neighboring teeth. It's less well defined, more of a milky lesion, but one of the diagnostic factors is you will tend to get, or you will generally always get, at least one of the first permanent molars affected by a hypermineralization lesion as well. And we can look at post-eruptive changes, so changes that have happened to the enamel once exposed to influences in the external environment. So a common one of these is going to be early caries. So you tend to get localized hypermineralization in areas where plaque accumulates. So for example, cervically in these sort of areas of poor plaque control. Another one you will quite commonly see is following multi-bracket orthodontic treatment. These lesions will sort of tend to follow the outline of the bracket in areas where the patient's oral hygiene during the orthodontic treatment has been less than adequate. Now, knowing the etiology is important because some lesions are harder to treat than others. Lesions which are more superficial within the enamel are easier to treat, and these would be the fluorosis lesions and the early carious lesions. Where the lesions are set deeper within the enamel, they are more difficult to treat. So these would be the molar incisal hypermineralization lesions and the trauma lesions, and I'll go into these in a little bit more detail as we go on. So why are these lesions white? It has to do with a phenomenon called refractive index. Every substance has a refractive index, and it is this which we use to measure how fast light passes through that substance. When light passes between two mediums with differing refractive indexes, it will change both speed and direction. And it's the differing refractive indexes between the mineralized and the hypomineralized enamel which gives rise to the lesion appearing white. So if we have a look at this slide, we have got some beads in a petri dish, and we have some writing behind the beads. Now, because there is air in the spaces between these beads, the air has a different refractive index to that of the beads, and because the light is changing speed and direction, we see a very distorted image, and we can't read the writing behind. Now, if we introduce a medium with the same refractive index as the beads, which displaces the air, the light is able to pass from the spheres to the liquid without changing speed and direction, restoring translucency, and it allows us to see through. And this is the basis on which we're going to look at the icon. So if we have a look at a cross-section of enamel, it looks a little bit like this. Enamel has a refractive index of around about 1.62. So the light will pass without interference to the ADJ, reflected back to the eye, so the eye will see the enamel as translucent. A cross-section of fluorosis looks a little bit like this. We have a fluorosis lesion with a refractive index different to that of enamel and covered by a surface layer of mineralized enamel. When light passes into this fluorosis lesion, because of the hypermineralized nature, there's lots of different refractive indexes. The light's going to bounce all around. It's going to create a phenomenon called a light maze. It's going to become very over-illuminated. When this light goes back to the eye is going to see this as white or bright. So what are our treatment options? These were our standard traditional treatment options. Now, whitening should always come first. With whitening, we're not looking to remove the white lesion, but what we are looking to do is raise the natural color of the tooth so that the contrast between the white lesion and the natural tooth is less, and often this can make the white spot less noticeable. Now, our traditional approaches were microabrasion or macroabrasion, so removing the tooth. Additive veneers, now in some respects you could look at this as being minimally invasive, but if you want to keep these veneers as thin as possible, whether they're composite or porcelain, you've got to go quite opaque, and then the end result doesn't look particularly great. And then you've got your sort of traditional subtractive veneers, whether they're composite or porcelain, but these were removing or covering the lesion. But in an ideal way, we would change the way that the light reacts with the lesion without removing it or covering it, and this is where infiltration comes in. So in 2009, DMG released Icon. Icon is a 3-stage treatment. It's a hydrochloric acid etch of 15%, and this is used to remove the intact surface layer of enamel. We have a 99% ethanol, and we have a low viscosity resin. Now, originally it was developed to treat the early enamel caries interproximally, but it was found to produce a favorable effect in the visualization of these lesions. Icon resin, because its refractive index is very similar to that of natural enamel. It is able to restore the optical properties. So the reason we use a hydrochloric acid etch is to get through this surface aprismatic enamel. Standard etch, phosphoric acid etch, it's not simple to remove this aprismatic layer. So the hydrochloric acid is able to get through this approximately 50 microns and produce a favorable etch pattern on the hypermineralized lesion, exposing the porous nature of this lesion and allowing the infiltration of this low viscosity resin. So what we would do is we would use the hydrochloric acid etch to remove the overlying layer. We'd gain access to this porous hypermineralized lesion. We'd infiltrate it with the Icon resin, which has a similar refractive index to that of natural enamel. It restores the translucency and allows the light to pass through. So with any treatment, it's best to have a set protocol, as this just makes everything a lot simpler and easier to follow. So just with any case, we always like to start with hygiene. 2 reasons: it gets the gums nice and healthy again, because healthy gums make for easier treatment. But also, if you have a look at this particular case, we have both extrinsic and intrinsic brown lesions, and the hygiene is just going to remove the majority of these extrinsic stains. So the next stage would be whitening. In a case like this would be for 2 reasons. 1, Icon only affects white lesions, so when we have intrinsic brown lesions on teeth, we want to get rid of that with whitening, and I'll go through my protocol for that in just a few minutes' time. And lastly, if the patient wishes further treatment, further resolution of these white lesions, we can go ahead with infiltration to remove the white lesion. So wherever possible, I like to start with home tooth whitening. As I said previously, the aim is not to remove the white lesion, only to make it look less noticeable next to the unaffected tooth. And the way that I've found in my hands to do this is through home tooth whitening being the most predictable. So my protocol, I do tend to exclusively use the Enlighten whitening system. They don't pay me. However, it's just I found this to be, in my hands, the most predictable whitening system that I've used. I like to start with 10 days of 10% carbamide peroxide at night, followed by 10 days of 16% carbamide peroxide, this ramped approach helping to limit sensitivity which the patient may get. Now, at this point, at 20-day point, I'm not reviewing the patient. And the reason I'm not reviewing the patient at this point is because during the whitening and for 7 to 10 days afterwards, the white lesions are going to look way, way worse. And it's really important to warn the patient of this at the beginning. Tell them that they're going to wake up their first day, they're going to take the trays out in the morning, and they're going to freak out because their teeth are going to look terrible. They're going to have even more white lesions than they even thought they had. This is normal. If you reviewed the patient as soon as they finished whitening, the white spots are going to look terrible. So we want to review them 7 to 10 days afterwards, giving the white lesions a chance to settle. And at this point, we're going to say, how does it look? And 2 things will happen. Either the patient, or 3 things might happen. Either the patients will say, do you know what? This looks really good. I don't notice the white lesions as much. I don't need any more treatment. Fantastic. We might look at the case and think, do you know what? Actually, you benefit from a little bit more whitening because your teeth could go whiter, in which case you might give them additional 16 or 10% carbamide peroxide, another maybe week of whitening, and review a week after that. Or we're going to have a look together and think, do you know what? This looks good, but we can get an improvement of the white lesions and then move to the next stage of treatment. It's this allowing the patient to see their teeth in the best possible light before making a next decision on treatment, which is really important because these patients often can't visualize how their teeth could look if they were just a little bit better. So for brown lesions, our protocol is slightly different. We need to warn our patients from the offset that the whitening is likely going to be extended over and above the initial 20 days. So remember, Icon only works on white lesions, so we must remove the brown lesions in their entirety prior to infiltration. I start again with 10 days 10% carbamide peroxide, 10 days 16% carbamide peroxide, but I will view the patient on day 20 at this point. I'm not interested in what the white spot looks like. We know it's going to look too bright. What I'm interested in is how the brown lesion looks. And then we're going to repeat with either, depending how the patient's got on with sensitivity, either more 16% or more 10%, reviewing every 7 days until the brown lesion is gone. This could be 1 week, 2 week, 3 week, a month, 2 months. It depends case by case. We'll then review the patient again 7 to 10 days after their last night of whitening and make a decision if any further treatment is required. So ICON is essentially bonding. As we all know, post-bleach bond strength is reduced for a short period of time. So in any case, we should wait 2 weeks after the last night of whitening before we attempt to do any infiltration anyway. So I'd like to share a case of one of my colleagues. This is Dr. Andrew Wallace, and this is a case which presented to him with relatively severe brown lesions. Now, the original treatment plan was going to be whitening and then either microabrasion or potentially some restorative work if the aesthetic result wasn't appropriate. Now, this is the patient after several weeks of actually 6% day whitening. It looks amazing. Now, we might look at this as dentists and think, well, there's lots of things that I'd want to change now. There's still white lesions on this canine, there's recession, there's different sized teeth. But for the patient, this was absolutely amazing. They were not even able to visualize what their teeth would look like with these brown lesions gone. And for them, this is fantastic. They don't need to do anything else. So it's allowing the patients to see their teeth in the best possible light before moving forward. So the first case I'd like to share with you, this is Mel. Mel is 9 years old, and she travelled from Wales to come and see me at my Bristol clinic. Now, she has intrinsic brown discoloration on her teeth, and these were affecting her quite severely. She was getting bullied at school, and she didn't really enjoy smiling. Now, a little bit possibly controversial, but whitening actually now is allowed by the GDC in certain circumstances under 18. However, the protocol is not the same as for someone over the age of 18. It's not something I'm going to get into on this presentation. I would advise, if you are interested in exploring this avenue of treatment for under 18s, to contact Linda Greenwall, because she has an absolutely fantastic protocol to follow. In this particular case, Nell and her parents were not looking for tooth whitening. So in a situation like this where the lesions are very superficial, we might opt for some microabrasion being the next step. So enamel microabrasion is a conservative method for removing enamel to improve discolorations limited to the very outer layers. The Sunfield et al. Study discussed that in an in vitro study, the enamel microabrasion techniques result loss of enamel in around 25 to 200 micrometers. So this is, depending on the number of applications, similar to that of ICON. So the technique involves making a slurry of hydrochloric acid and pumice and using a slow speed handpiece with a brush or cup attachment running at no more than 500 RPM. We're going to massage this into the tooth surface with gentle pressure. Now, you can do this in two ways. You can either buy a pre-mixed 6.6% hydrochloric acid and pumice slurry. This is on sale by Ultradent, and it's called Ultraluster. Or you can make your own with the ICON Etch. However, remember the ICON Etch is 15%. So the protocol will differ slightly depending on which you choose. Always start by isolating the gingiva with a liquid dam or a rubber dam, because you don't want to get this onto the soft tissue. The protocol, as I said, will differ depending on which you choose. The 6.6% solution by Ultradent, you're looking at 60-second applications repeating as necessary. However, if you're using the homemade sort of 15% ICON Etch pumice, you're looking at 5 to 10 seconds applications, 4 max applications. And this is what it will look like, or this is what it could look like. The brown lesion is pretty much gone. The white lesions look a little bit worse just because the tooth is desiccated. So finally, you place a fluoride varnish over the treated areas. I made a slight error here. I used Durafat, so it's going to temporarily stain the teeth and ruin your post-op photographs, but that will aware of. So start to finish, after our initial conversation, this treatment took less than 10 minutes. But for me, this was one of the most sort of satisfying and emotional cases I've ever done. This little girl and her mum, and I'm not ashamed to say myself, we were pretty much all in tears at the end of this because she was just so happy. My only regret is I've never got a rehydrated photo as they traveled 4 hours to see me. So anyway, we're going on to Icon, which is why we are all here. I'd like to introduce Joanna. Joanna is the girlfriend of one of my good friends who actually is also a dentist. She'd whitened her teeth, and this was the end result. Good result on the actual tooth color, but the white lesions are still very prominent. So she's got characteristic signs of fluorosis, chronological banding, this white parchment-like appearance, and a very minor brown lesion on the upper right one. So as we are working with a strong acid, good isolation is of the utmost importance. As we mentioned, we don't want to get this onto the soft tissue, but also isolation is going to maximize our visualization of the working field. So this was one of my first Icon cases. We can see my isolation was far from perfect. The papillae are poking through the interproximal areas, and because these areas were exposed to the Icon etch, this resulted in some burns on the gingiva. Luckily, this was my nurse, so she was quite understanding, but ideally we don't want this to happen in any case. It does heal, and this next photo was a week or so later, but we want to avoid this wherever possible. Something else to bear in mind is you have access to the entire white lesion. So if the dam covers part of the lesion, then you're not going to be able to reach it with the etch or the infiltrant, and it will not be effective. So a situation like this may have been more appropriate to work with floss ties to achieve a little bit more visualization and access to this white lesion by providing more retraction. So the key point for me regarding rubber dam is inversion of the rubber dam. This means tucking the rubber dam into the gingival sulcus. This creates a seal around the neck of the tooth, and it prevents saliva and gingival curricular fluid from leaking onto the working slide, as well as protecting the soft tissue from anything which we're using onto the surfaces of the teeth. Achieving it is not as complicated as it looks, and I'm going to try and run through rubber dam in about 4 or 5 slides. So a simple recipe, this is my recipe. First is a high quality dental dam. I like the Unodent, the Dental Directory, own brand, latex free, light blue, heavy gauge. This is the order number here. It's actually one of the cheapest dams on the market, so your principals will thank you for this. The next is a multi-hold punch. So the size of the holes is key. Too large and the dam will not be tight enough around the neck of the tooth to maintain inversion. Too small and the dam will tear as it goes over the tooth. Single hole punches generally create too large a hole. They're great for single tooth RCT, but what you really need is a multi-hold punch. The central is really going to use the smallest or the second smallest hole, premolars, second, third, molars, fourth or fifth smallest hole is generally sort of the rule of thumb, which I work. Try to keep it simple with a limited number of clamps. If we're doing full arch isolation for Icon, we tend not to use any form of anesthetic. So if we can use a clamp that is relatively flexible, we don't need to anesthetize the patient for the clamps. The Kerr clamps generally fit in most situations on 6s. However, because they are more flexible, if you have a less retentive 6, they might start to ping off. So if that's the case, I'll use a W56 wingless clamp. It's also useful in situations where we like, if we're going to place the clamp before the rubber dam. My preference is generally for wingless over winged clamps, unless I'm working with the Kerr soft clamp. So just to show you how quick it is, I've got 2 videos that I would like to share with you. The first is how I mark the holes on the teeth. So I put the rubber dam onto the frame and I find where my front teeth are going to be. Now there are stamps available for this, and if you're just starting out, it might be worth using a stamp because it helps you space the holes well on the rubber dam, because if the holes are too close together, you tend not to be able to compress the papilla. But after a bit of practice, you can sort of freehand it, and this is sort of the result that we are looking for. Just note the space between the holes. This allows, especially if we're using a heavy gauge dam, to work the dam between the contacts. If you struggle here, I would get your assistant just to help you with a little bit of floss. With the floss though, I would tend to go up and down. I wouldn't try and pull the floss out the side because this has the habit of tearing the sheet of rubber dam. So I'm going to work one quadrant at a time. I'm going to work all the way back to the 6. I'm going to hold that in place. And either myself or my assistant is going to place the clamp over the 6. What we'll then do with some floss is we will floss mesial of the 6, because often you can't do this prior to the clamp going on. And sometimes the floss breaks. You see I'm going up and down. I'm not pulling the floss out the side. What we'll then do is, at the moment we are a minute 20 in. I'm just going to fast forward through the next quadrant. So we are now still under 2 minutes and we are 90% there. What you can see is because it's a heavy gauge dam, because the holes are appropriately sized, the majority of the teeth have the dam inverted around them. Any sort of stubborn areas, what we then do is we will work around with our floss, just encouraging that rubber dam to invert into the sulcus. There may still be some stubborn areas that we can't quite get with the floss. In that case, what I will do is I'll get my 3-in-1, I'll pull the dam slightly away from the tooth, and I will just dry the tooth. And this drying of the tooth surface is generally enough to allow the rubber dam just to invert itself. If you have a look at the canine, you can see, pull it away, bit of air, and the rubber dam is inverted. So that's a full arch isolation in under 3 minutes. It will not be this quick the first few times you do it, but if you spend this little bit of extra time at the beginning, it's going to make the rest of your life a whole lot easier. So we have put on our rubber dam, we've isolated, and then just what I like to do is just condition the surface of the enamel. Do with this 27 micron alumina. Just is going to help us, in removal of this superficial, this aprismatic layer. And if you don't have a sandblaster, well, I would advise you get one, but you can use some pumice water slurry just to help clean the surface of the teeth. So after surface conditioning, we're going to apply our first round of hydrochloric acid etch. This is applied to the white lesion for 2 minutes. Now in this particular case, we've put it up the whole surface of the teeth because there was some degree of white lesions on the whole surface of the tooth, but you would tend to only apply it to where the white lesion is on the tooth. This is going to be on for 2 minutes. We're then going to thoroughly rinse that off with water before drying the tooth. The next step involves the ethanol, and the ethanol, in my opinion, is one of the most, or is probably the most important step. Because what the ethanol does is we'll pop the ethanol onto the white lesion and we're going to keep it wet. We're going to keep putting ethanol onto the white lesion for at least 30 seconds. Because the ethanol has a very similar refractive index to that of the icon infiltrant, it's going to tell us if we were to infiltrate with the icon now, would we get a satisfactory result? So if we view the white lesion through the wet ethanol after 30 seconds, if the white lesion has disappeared, then we'll know that doing our infiltration now will lead us with a satisfactory result. If the white lesion is still visible as it is on the upper left one, we'll know that we won't get resolution of the lesion if we were to infiltrate now. So from this image, we can see the upper right one is good. The upper left one needs a little bit more. So what we're going to do is just repeat the etchant on the resistant portion of the white lesion for another 2 minutes. You'll do this followed with another ethanol trial after rinsing and drying. And you repeat this until you are satisfied that when we apply the ethanol, the lesion is no longer visible. What we will then do is we will apply ethanol to everything and allow it to fully desiccate for 30 to 60 seconds. We want no water left on this tooth at all. We want these lesions to be as dry as possible, so they're going to draw as much of this icon infiltrant into the teeth as possible. So you can see that with this slide here, as the cycles of etch and ethanol progress, we can just see how the lesion will change as viewed through the wet ethanol. So you can see the middle after a couple of cycles and the far right of the screen with a satisfactory infiltration of the ethanol. So once we are happy, we're going to turn, if we're working with our looped headlight, we're going to turn our looped headlight off. We're going to turn our chair light off, but it's okay to have the room lights on. The reason we're going to turn our lights off is when we apply the icon resin to the tooth surface, we're going to let it sit there and be drawn into the white lesion for 3 minutes. And we don't want to prematurely polymerize this. After 3 minutes, what we want to do is we want to floss the contacts. And I like to remove as much of the excess from the surface of the tooth as possible with some cotton wool. Remember, we're not looking for a layer on the surface of the tooth. We're only interested in what is being drawn inside the porous white lesion. After excess removal, we're going to cure the lesion for 60 seconds. Now, depending on the size of your curing tip, you might need to do this a number of times per tooth. If I'm working on more than 2 teeth, I like to work with 2 curing lights, because what I found is with more than sort of 2 or 3 teeth for 60 seconds, your curing light can overheat and stop working. So I tend to have one, my assistant will have one, and we'll sort of meet in the middle. So after we've cured, we're going to repeat the infiltration again, but this time only for 1 minute. We're going to floss, remove the excess, and cure again. Your final appearance will look something like this. To the best of your ability, you'll have removed as much of the resin from the tooth surface as possible, but you won't have got everything, so you will get left with this rough excess resin on the tooth surface, and it's very important that you remove this. If you don't, it's going to feel pretty bad for the patient. It's also going to pick up stains relatively quickly. Don't use burrs, don't use discs. The thing that I've found most suitable for removal of this excess resin is the Astropol kit from Ivoclar, working through the blue, the green, and then the pink impregnated points is going to leave us with a lovely natural luster on the tooth surface. So you can see immediately post-op, and then a couple of months later, that actually the result is going to look even better as the tooth naturally rehydrates. And what I find just sort of really amazing about this treatment is just how we're able to restore the natural incisal effects with really not very much work on our behalf. We sort of sit there, we rub some gels on the teeth, we wash it off a little bit. Trying to layer this in with composite resin is not impossible, but is certainly very, very difficult. And just sort of this is a 4-year follow-up, you can see the results are stable over time. So this technique where we are focusing on just the etch and the infiltration has been sort of coined the name erosion infiltration. So this is where we are just relying on the icon etch and infiltration. And we've got a little live video of just how this will look. And this video is available on YouTube should you wish it. So we've isolated and we're going to apply the icon etch onto the white lesions for 2 minutes. We're then going to remove the excess. We're going to rinse and dry the teeth. And we're going to apply our icon dry, our ethanol solution, for at least 30 seconds and then view it while it is still wet. If the white spots remain, we're going to repeat the etch process, 2 minutes. We're going to repeat the icon dry, the ethanol, until we are satisfied. We're going to desiccate fully. We're going to remove any excess with air. We're going to turn off our lights and we're going to apply our icon infiltrant. Removing excess, flossing contacts. You don't want to stick your teeth together, that's for sure. And we're going to cure. We're going to repeat the infiltration, this time for 1 minute. Removing the excess, flossing and curing again. And then remember spending the time polishing. And a nice result. So that is available on the DMG EN YouTube channel. So as we discussed earlier, Icon works through restoring the natural translucency of the enamel. The benefits of this are obvious, the removal of the white lesion. However, there are some perceived effects which we must warn the patient about. Now, the first one is the relative brightness of the teeth. Now, depending on the initial severity of the lesions, removal of these white lesions could, if the white lesions affect a large proportion of the tooth, could result in the smile looking less white than before. Because remember, we're not making the tooth the same color as the white lesion, we are making the white lesion the same color as the natural tooth. Most patients is not a concern for, but it is something that I would always warn them about at the beginning. The other thing I would warn my patients about is the potential increase in the visibility of the incisal opalescence. This is one of my favorite cases I've ever done. I was so excited about this case just because of how the incisal edge looked at the end. But actually the patient complained that I've made her teeth look see-through. So again, if you discuss this at the beginning, it's a warning. But if you tell the patient at the end, it can come across just as an excuse. So my next case I'd like to share with you is Vicky. So she didn't like the white and brown lesion on her upper right one. Her teeth were also darker than average, and she also had a stippled appearance of her laterals and her canines. So this is a case of molar incisor hypomineralization. Histologically, it's a little bit different from fluorosis. With fluorosis, the lesions tend to start superficially within the enamel layer and working deeper as the severity increases. Now this is a little bit different in MIH. An MIH lesion originates at the ADJ, meaning it's going to be covered by a thicker layer of mineralized enamel. So this would be our cross-section of fluorosis, covered by our thin layer of mineralized enamel, easily removed with a hydrochloric acid etch. However, the MIH lesion is deeper, covered by a thick layer of mineralized enamel. Either going to take a great number of etch cycles to get through, or it won't be possible at all with just the Icon etch. So we need to gain access to the lesions, and one of the most predictable ways of doing this is through sandblasting with either 27 or 50 micron alumina. So as per our protocol, due to the presence of the brown lesion, we're going to start with whitening to remove the brown lesion in its entirety, and also to homogenize the tooth color as well, reducing the contrast between the white lesion and natural tooth. This was the result. It was a pretty blinding result. She did a little bit extra. It's when I worked in Essex, and this was the look that people like to go for, and they got a really nice result. But just remember, this is the most unpredictable step, and it can take weeks or months to remove a brown lesion completely. So we've isolated, and we're going to spend some time with, in this case I used a 50 micron alumina to remove the overlying sound enamel to gain access to the porous lesion. Now this is going to create a concave defect that isn't going to be filled by the Icon resin. And this is really important because we need to bear in mind that we're then going to need to restore this in some way. The easiest, most conservative way is going to be with composite resin. We're then going to, as before, start our process of etching and previewing until satisfied that the lesion will go. We're then going to desiccate it. We want to make sure the lesion, as our checklist, is disappeared when viewed through wet ethanol, but the lesion is going to be still visible once it's fully desiccated. We're going to apply our infiltrant, turn our operator light off, infiltrant on for 3 minutes. We're going to remove our excess, and we are going to cure the tooth. We're then going to repeat this infiltration for 60 seconds, and then we're going to cure again. Now, after that, our job is relatively simple. Because we are just replacing enamel, we can use a single shade of enamel shade composite, which we'll have shade matched at the beginning, to restore the lost enamel on the upper right one, and also to smooth out the defects on the other anterior teeth. We're going to etch the canines and the laterals. We're not going to etch the lesion we've infiltrated. Now, Icon resin, it will create its own oxygen inhibition layer. However, the studies do show that the use of a conventional bonding agent does not impair the bonding to the infiltrated enamel. It will actually improve bond strength in many cases. Following that, we're going to apply our single shade of enamel composite resin to the laterals, canines, and our defect on the upper right one. And this is the result 2 weeks later. Again, huge result from a minimally invasive treatment. We're allowing the natural anatomy to shine through, giving this patient back their confidence in their own smile. So this technique, where we're combining the use of composite resin, sandblasting, and resin infiltration using Icon, has been given the name deep infiltration. So far we've looked at cases where we have whitened, where we are able to sandblast, and we've looked at sort of mild to moderate cases. What if the patient doesn't want to whiten? What if the lesion is very extensive and it will take a great deal of time to sandblast? Or if you don't have a sandblaster, and I would always encourage people to get a sandblaster. It's one of the greatest aids in adhesive dentistry. It's arguable, can you carry out adhesive dentistry without a sandblaster? But that is a whole other conversation. Now, this is Albert. She has a pretty intense hypermineralization on her centrals with a pretty intact surface layer, and we can see that actually the surface of these lesions are quite shiny. She had darker than average tooth color, but she didn't want to whiten her teeth. Now, we know from earlier in the lecture that whitening makes our job a lot easier, as it will reduce the contrast between the tooth and the lesion. But at the end of the day, if the patient doesn't wish to whiten, we can't force them. Now, a question I often get asked is, can you whiten after infiltration? The answer is yes. Because remember, this is not a layer on the surface of the tooth. We're only putting the Icon infiltrant into the white lesion, so you are still able to whiten the teeth after infiltration. Now, if you're combining with composite resin, obviously you need to have the conversation that composite resin doesn't change color. So if they were to whiten afterwards, they may need to replace the composite resin if you have used any. Now, in a particular case like this, where I know I'm going to get a better result with whitening, I know I may need to be less invasive. I would have a conversation with the patient at the beginning. I would say, now what we're going to do is we're going to try to remove these white lesions with infiltration only. What I'm going to do is I'm going to do my maximum 4 etch cycles and my preview stage, and I'm going to show you what this is going to look like. If you are satisfied with the result at this point, give me a signal. That's generally going to be a thumbs up, and I will know that you are happy to achieve this result with infiltration, and it's unlikely to be 100%. If you want these white lesions gone completely, if you're not happy with the result after 3 or 4 etch cycles, give me a signal, generally be a thumbs down, and I will know you have given me your consent to remove further enamel and restore this with composite resin in combination with the Icon treatment. And that's exactly what we did. So we isolated, we carried out in this case it was 4 cycles of etch and preview. The reason I stopped at 4 is because more than this and you're getting into the territory of creating a defect with the etch. And this was actually the result. It actually far surpassed my expectations of what it would look like with just the ethanol. And I was half expecting the patient to say, yeah, no, that's good. But she wanted it gone entirely. She wasn't satisfied with this result. Because these lesions were quite deep, because we were fairly confident that there was a fairly substantial layer on the surface, in this particular case, I used a rugby ball shaped red diamond burr to remove a very small amount of the surface enamel, round about sort of 0.1 millimeters of facial enamel. We're not cutting the lesion out. This is what it looked like after. We're just gaining access. I mean, inevitably we'll remove some part of the white lesion, but we're not looking to cut it out completely. We're just looking to gain access to the lesion, as you could have done with sandblasting. It just would have taken quite a long time. We go back with our etch and with our preview, and just with one cycle of etch, this is the result at preview. So now we know that if we were to infiltrate, we would get complete resolution of the white lesion. However, we would be left with a defect that we need to fill with enamel. So we desiccate, we infiltrate, we still have our defect, but it's very simple to replace with a small amount, single mass, enamel shade composite. Very simple, no layering, no stratification. Brush it flat, polish it, and get a really nice end result. Now the last case type I want to go through is trauma. So trauma is the one of the least predictable lesions that we can treat, and there's a reason for this. If we look at a cross-section of fluorosis lesions, it looks a little bit like this. The angle between the surface enamel and the lesion is greater than 90 degrees. This means it's very straightforward for us to penetrate the entire depth of the lesion, because it gets narrower as it gets deeper within the enamel. So by removing the overlying enamel, we generally get full access to this lesion. Now with traumatic lesions, the angles are a little bit less predictable. Sometimes the base of the traumatic lesion is wider than as it approaches the surface of the enamel, so it's a lot less predictable to fully infiltrate. And in some cases, you can get left with sort of this ghost halo around a lesion. So in these deeper lesions, we still need to adopt the deep infiltration, and we need to do a little bit more sandblasting, especially around the periphery of these lesions, in order for us to facilitate full infiltration. So again, we have our patient. We're going to isolate. We're going to sandblast, not to remove the lesion, just to gain access. We're going to create this defect. We're going to apply our etch, and we'll continue our etch and preview until we are happy that the lesion is not visible through the ethanol. We will apply our icon infiltrant. We'll have a resolution of the lesion, but the defect will still be present. Apply our bond, our single mass of enamel shade composite, to get a really nice result. Now, something that I always get asked is icon profitable to do in general practice? What is a reasonable amount to charge? What I say is charge for your time. Remember, there are other options available to this patient, but they are generally more expensive, both biologically and cost-wise. So let's have a little look at the breakdown in fees. So I'd say the average charge for home tooth whitening in the UK is around about £300 to £550. Some areas it might be a lot more, central London, some areas it might be a lot less. Now for icon, what I tend to charge is not per tooth, is per arch. The reason being is whether I'm doing 1, 2 or 6 teeth, it's generally going to take me around about the same amount of time, because most of that time is just waiting around, waiting for the etch to work, waiting for the ethanol to penetrate, waiting for the infiltrant to go in, and then polishing. So I would tend to say if you're starting out, I would maybe book an hour and 20 for your first case and a 20-minute review. But as you get more experienced, you might be able to knock that time back a little bit. I would tend not to book in less than 45 to an hour for a simple infiltration case. But let's say 100 minutes of treatment and review. Material costs, depending on which whitening system you use, it can vary greatly, but let's say average cost for trays and gel is £100. And the cost of Icon per kit is around about £50 per kit, depending on how many you buy and where you get it from. So our total profit, we're looking around about £545 to £1,000, which per hour chair time is £234 to £429, which is pretty good going for you just sitting there, not doing very much, playing on your phone while this sort of Icon does the work for you. So it's a very profitable procedure, and it's respectful of the patient's biological tissues. How long does it last? Well, at the end of the day, how long does any of our work last? What do we quote our patients for composite bonding? What do we quote our patients for ceramic veneers? Now, what I say to my patients is Icon has been around since 2009. So far, there has never been a case that's relapsed. However, I can't guarantee you that this will never happen. I can't guarantee you won't wake up and the lesions will be back. I can't guarantee that you won't wake up and they'll be purple. I actually say that, and that goes in the notes. It's very unlikely this will ever happen, and what we've actually found is the results of these lesions tend to get better with time because the teeth will rehydrate. But at the end of the day, if this patient had gone for composite resin, that's going to need to be replaced 5 to 7 years. Ceramic veneers, 10 to 12 years. So even if this patient does need something further on down the line, you've saved them one round of invasive restorative dentistry. But what I'd like to do is leave you with a video from one of my patients, because really she says it better than I could ever.
I've been bothered by the white spots. Maybe as I got older, I got less bothered. But I was bothered by the white spots because often people would come up to me and say, "What are those?" Actually point to my, teeth and go, "What are those marks on your teeth?" And kids as well, they would do it. So that would be kind of bothersome. And just that I couldn't smile so wide, and I have a naturally wide smile, so it would bother me that way. My dentist introduced me to Icon. I thought it was like serendipity. It was so like unexpected because I'd come in for a different reason, because of a retainer that I have in my mouth. And then it was the first time I actually met Richard, because my dentist was ill, and he just said really casually and nicely, "So do those white marks bother you?" And I was like, "Yes, I've been looking for something for the past 10 years more." And then he goes, "Well, have you heard about Icon?" The treatment was brilliant. Like, I had no trouble. I didn't feel uncomfortable at any point. I was fully aware of what it entailed, what was going to go on. Richard explained the steps before thoroughly. So in the chair, I felt good. There was no certain time where I felt I needed to stop or anything. It was plain sailing. It was smooth. I love the result. It was brilliant. Like, I was shocked. I actually did think they're all gone. Like, they're just gone. And for some reason, maybe the back of my mind thought I'll have a little mark or something. But I didn't even realize how kind of prominent they were. They're just brilliant because they're gone now, and it's like almost like a new set of teeth. I think the cost of treatment is reasonable. I think it's worth it. You get the result, you get a fantastic price you're paying, especially if I was maybe going to go on other avenues or other routes. Definitely, I think it's worth the price. The treatment will definitely change my life positively, or affect my life positively, because I don't have to think about not smiling so wide anymore, or someone standing too close, or there won't be anyone pointing up saying, "What are those marks?" or "Where are they from?" And I don't have to go through that whole story of where I got those marks to start with. So it can only be more confident, more feeling better, smiling brighter, and just laughing more.
So what we have is a treatment that not only restores the natural translucency of these lesions, but it's a treatment that also restores confidence in people who've been affected by these lesions for as long as they can remember. It is a truly fantastic treatment, one that I not only enjoy sharing with my patients, but also with my colleagues, in the hopes that you'll be able to offer this to your patients as well. Thank you very much for your time. I believe we're going to have some questions now, so I'll try and answer as many of them as possible. If I don't get to your question, please feel free to email me. This is my email address. Have a look at my website, add me on Instagram, any way that you want to message me, I'll get back to you as soon as I can. Thank you very much. Okay. Okay, so we have some questions here. How many attempts are allowed before we stop in case of unsatisfactory results? So what I would say is, if you do 3 etch cycles, I'd say that is the most I would do without infiltrating. If you do 3 etch cycles and decide not to infiltrate, I would apply some fluoride varnish and just tell the patient to avoid anything sort of overly acidic to eat. But you generally have the conversation with the patient at the beginning is, if we do this, we're either going to infiltrate or you're going to tell me that you're happy for me to proceed with something, a combined approach with composite resin. After you place the ethanol and you're happy, do you wash away the ethanol, then dry or air dry the ethanol? Certainly air dry the ethanol, because if you wash it away, then you're reintroducing water, and if there is water in the lesion, you're not going to get penetration with the ethanol, with the icon resin. Do you need to wait any time after doing icon before placing composite? No, it's actually better to place the composite straight away, because if you wait, you then have to recondition the tooth, and you're going to have to deal with it as a combined enamel and existing composite. So I would say if you're going to place composite, it's easier and much straightforward to do it at the same appointment. I would just add to the oxygen inhibition layer with a standard bonding agent and place your composite straight away. Question to get relapse. I think we've answered that. Oh, 2 seconds. So far, no relapses have been recorded. I think a lot of these are about bonding, which I think we have answered. That was a good question. Do you sandblast before the rubber dam goes on? Now, absolutely, fantastic question. I would always try and sandblast before the rubber dam goes on. The reason being, if you sandblast with the rubber dam on, it's fine, but you have to spend a lot of time cleaning up the rubber dam. If there's any particles left, and you knock the rubber dam, especially when you're infiltrating, if these particles get stuck in the infiltrant, it's a nightmare to remove. So yeah, if possible, I would sandblast before the rubber dam goes on. Excellent question. For MIH cases where you need to use composite, do you restore composite immediately? Yes. So it's you've made your defects, so you'd need to replace composite straight away. Do I use hemostatic agents in the gingiva prior to placing the rubber dam? If your gingiva is bleeding, it means your oral hygiene is not up to scratch, so I wouldn't do any form of sort sort of restorative dentistry in a patient with poor oral hygiene. So no, you shouldn't need to use any hemostatic agents prior to placing the rubber dam. Is there specific dietary advice for the patients after the procedure? Is the legal age the same as whitening? So dietary-wise, I would probably say just avoid any sort of, same as you would give for anyone with composite bonding, maybe for the first day, try and avoid any overly staining foods. But in terms of the age, there is no minimum age. What I would say is the patient has to be able to tolerate being in the chair for 45 minutes with the mouth open. In an ideal world, they need to tolerate rubber dam. And if the patient is under 18, I would probably limit it to 3 etch cycles just because of the size of the pulp chamber. But there's no minimum age, legal age, it's just more about patient compliance. About how do we charge, but we covered that. Second, would I recommend any courses before carrying out? What you can actually do is if you contact your local DMG rep, what they will actually do is they will help you vet a good starter case. And then if you can book this patient in towards the end of the session, it's often possible to get your DMG rep to be there with you during the time that you carry this out. So that would be what I would recommend. The DMG reps, we tend to send any questions to myself or the other KOLs. We'd say, yes, this is a good starter case. No, it's not a good starter case. And for a good starter case, with the DMG reps, we try to be with you, if possible, on your first case. What is the reason the incisal edge becomes more translucent? So it's not that it's becoming more translucent, it's just you are restoring the natural translucency that would have been there should the white lesion have been absent. So for example, you look around at some people, they've got really sort of translucent, really lovely incisal anatomy. Look at someone else and they don't. It just depends on person to person, but often you can't tell, so it's good just to give the warning to the patient beforehand. Difference in additive and subtractive veneers, so it's whether it's effectively non-prep or prep veneers. I think we've answered these. How do you isolate if a patient has a fixed retainer? So you can either do liquid dam or a combination of split dam and liquid dam. Does this make the teeth really sensitive if doing without local anesthetic? Remember, you're working entirely within enamel, so there should be no post-op sensitivity. The only times where I would give local anesthetic would be if the patient wasn't able to tolerate the clamps, or if I needed to use floss ties and the patient, again, wasn't able to tolerate the floss ties without local anesthetic. Someone's just asking again for the name of the Ivoclar points. That's the Astropol kit. I would say you'd spend the same amount of time polishing the teeth as you would polish just standard composite restoration, so however long that takes you. Is there evidence of the resin yellowing over time? So far, no. Fantastic. So I think that is all of the questions. Thank you very much for spending your afternoon with me. Again, if there's any questions that I've missed or haven't answered, please feel free to email me. Again, my email address is richardfield richardfield@me.com, or send me a message on Instagram at Dr. Richard Field.